Assalamualaikum and salam sejahtera. I'm Dr. Jasmin, clinical oncologist. I earned medical degree from University of Malaya and I've completed my clinical oncology training at the Royal College of Radiologists in London. Today, I'm excited to share a significant achievement in treating tongue cancer at PPUSMB, Kepala Batas. Before we delve into the details, I want to acknowledge the graphic nature of the upcoming content. If you find it challenging, please do consider covering your eyes or look away momentarily. This image portrays the harsh reality of tongue cancer, a devastating disease with a low survival rate. Survivors often find it difficult coping with the effect of the surgery or without any treatment, and the impact extends beyond health, affecting one's ability to speak well. And for those who are in the professions of singing, speech therapy, or promotion, the challenges are immense. In 2020, it ranked fourth in incidence with 160,000 new cases reported in Southeast Asia. Sadly, around 90,000 individuals succumb to this disease and approximately 300,000 people live with its prevalence. As you can see here, the current standard treatment involves operation by taking out half or all part of the tongue and replace it with a tissue either from surrounding area or from other part of your body. Then they will subsequently have radiotherapy or IMRT, as you can see from this image, with or without chemotherapy. That will depend a lot on the risk involved from the surgery itself. While brachytherapy has been used only in a small tumor at the base of the tongue and hasn't spread to any nearby lymph node. However, not everyone is suitable for the surgical resection mentioned earlier. Some are medically unfit for lengthy operations, while others refuse surgery completely. Furthermore, surgery can leave patients with lesser quality of performing the basic functions of tongue, such as eating, drinking, tasting, speaking, and swallowing. This directly impairs the overall quality of life. Therefore, we at PPUSMB propose to some subset of a patient, not all, but some of them, who wish not to go for surgery, but still wish for a curative treatment to opt out of surgery and replace it with the brachytherapy mentioned earlier, but we put it as replacement for the surgery, while still keeping the radiotherapy and chemotherapy component of the treatment. And we name it HyBIRT, which stands for hybrid brachytherapy followed by IMRT. Well, I'm not asking patients to completely leave surgery aside while it is still the standard of care, but what if the patient could not undergo a very long hours surgery for medical reason? What if the operation theatre is not available? And what if the queue for the operation is unbearably long? Brachytherapy is a type of cancer treatment that involves placing a radioactive source directly into the tumor. So the term brachy comes from the Greek word for short distance. During brachytherapy, a device called an applicator is inserted into or near the tumor, delivering a high dose of radiation to the targeted area. The one you see over here is interstitial brachytherapy, where we directly put the radioactive source using the applicator directly into the tumor. Surface mold also one type of the brachytherapy, but this is not invasive, means we are not poking, we're not injecting, we're not cutting, we're not putting anything inside the tumor, but we put right on the skin of the patient for patients who suffer skin cancers. So next, what is IMRT? Because IMRT also part of the component of the new treatment. IMRT basically stands for the intensity modulated radiation therapy. It is a precise way to deliver radiation to cancer treatment Unlike traditional methods, IMRT adjusts the strength of the radiation and beams to match the shape of the tumor, minimizing the side effect to the surrounding healthy tissue. So the term HyBIRT is a combination of brachytherapy and also with the IMRT. Here how it is done. First, we insert the brachytherapy applicator, and then we plan the brachytherapy treatment and we administer the treatment. The brachytherapy session takes only around 5 to 10 minutes, and it is repeated 5 times, 6 hours apart over 3 days. Then we move to IMRT, where the patient is going to have 33 days of treatment with total treatment duration of around 56 to 60 days. The photo you see here is about a patient who suffers a cancer, as you can see on the left border of the tongue. But wait until you see the next image. So the blue dotted lines that you see over here is the true extent of the tumor. Maybe you have seen earlier picture and thought that the tumor was small, but as you can see over here, after a careful examination done under the anesthesia in the operation theatre, we appreciate that the tumor was way bigger than it is. So we proceed by inserting the brachytherapy applicator. The light blue needle that you see here are the applicators serving as the conduits for the radiation source to move right to the target, which is the tumor. And this marks the end of the applicator insertion process, where you can see the yellow button, which is the silicone material that we put to prevent the movement of the catheters. And this is the part of the planning of the brachytherapy. After we have inserted the catheters, we scan the patient, and the image that we got from the scan will be used to do the brachytherapy planning. I hope you can appreciate the colors there. The blue representing the lowest dose delivered by the brachytherapy, and as you can see, it is a very, very focused radiation. No other type of radiotherapy can match the sharpness of this dose delivering method. This is the place where our patient will sit comfortably and have the radioactive tube connected to their applicator before and have the treatment around 5 to 10 minutes. After the patient has successfully underwent brachytherapy, now it's time for the radiotherapy. Unlike brachytherapy, this method doesn't involve insertion of needles or radioactive source. Instead, the patient lies down on radiotherapy couch wearing a mask and have a scan done again. And this phase of radiotherapy will take around 33 days, and is occurring between Monday to Friday, and it approximately takes around 15 minutes every session. So the photo here is a CT scan taken from different angles that shows how we modulate the dose from the brachytherapy and also the dose from the radiotherapy. As you can see, the thin yellow line at the tongue part of the image is basically a dose from the brachytherapy. I hope you can appreciate the red line, how it avoids touching the thin yellow line there. That is to avoid the high dose region to the area that we have treated with the brachytherapy. That will directly reduce the amount of side effect that will be experienced by the patient. So how are we doing so far? We have treated so far 40 of our patients since 2019. 97% of them had an excellent local control at 2 years, and all of them, 100% of them have their tongue preserved, and 90% functional preservation. Therefore, this is a very promising outcome. And in 2022, Brachy Academy by Electa has accredited IPPT as one of the education center focusing on liver, head and neck, rectal, esophagus, brachytherapy. We are the only center with the expertise of the tongue brachy in the Southeast Asia. Electa also has agreed to supply 300 catheters, the applicators, for our ongoing study, but yet to receive the material as the agreement between the company and the USM is still underway. This among the real stories shared by our patient, and these are presented in the international website of Electa. Dr. Lu, also one of our patients, has voluntarily shared his own success story of undergoing brachytherapy in the Electa website. We have also presented a paper in ISTRO, one of the well-known European Society of Radiation Oncologists, about the method that we use to treat the lung cancer. And again, this year, we were selected again to present about the quality of life that the patient undergoing HyBIRT treatment, comparing with the conventional surgery and radiotherapy. So what are the challenges that we face? Among them, the side effect, the cost, and of course, this method, we found that it is unknown to many people. So about the side effect, the photo that you see over here, we call it in a scientific term osteoradionecrosis, but in a normal term, it's just simply jaw bone basically exposed by the destruction of the gum tissue. This is one of the common side effects, not only to the HyBIRT patient, but also we found it in the patient who underwent surgery followed by radiotherapy. But the rate is slightly higher in the HyBIRT patients. So we are calling all the dental experts, nutritionists, oral healthcare specialists, rehabilitation specialists to contribute on helping hand in hand with us to treat or prevent this from happening. I know that this is a common side effect for both conventional approach and our approach, but if we could solve this once and for all, it would be a perfect score for us. Next is the price of the brachytherapy applicators, those blue needles. I hope you still can remember those things. Can someone here just tell me, don't worry doctor, let me see. I think we can produce it locally. So these applicators, as you can see, number 1, number 2, number 3, number 4, are the applicators, the buttons, the stop tag, the lower buttons. All of these, well, I'm not a material expert, but I really hope some expert could come up front and tell me that this can be produced locally. The third challenge is very few people know about this, because majority of patients who comes up front tell us that we never know about this. If we would have known about this, we would not agree for surgery. There are two main factors here. I would put one from the doctor's side, the other one is from the patient side. As for the doctors, there are few possible causes and unanswered questions. Among them, is there any evidence that is working? We may have yet to come up with a publication from the top journals due to the short interval of observation, which is 5 years, but 2 years in a row, ISTRO, the renowned European Society of Radiation Oncology, has accepted our presentation last year and this year. We will get there one day. So that this method of treatment in the future, proven and accepted as a standard of care, would benefit many, not only our patients, of course primarily, our university and our proud country. In conclusion, HyBIRT presents a potential alternative for treatment of tongue cancer, aiming for excellent local control and also, of course, preservation of the tongue function. And we anticipate that this novel approach would trigger many more studies in the field.